So we're going to cover kind of a high-level overview of some market issues, industry, and trends specific to our space and healthcare in general. Do a PQRS update, talk in several places about the MIPS program, or the Merit-Based Incentive Payment System. A little update on Therapy Cap. It's still around. It's still here, even though we're not scrambling to have legislation passed before the end of the quarter this year. Talk about some of the innovative and alternative payment models that are going on in the Innovation Center at CMS. There's more and more of them, and we've got some new ones coming this year as well. Some additional regulatory updates we need to be aware of in our area, physical therapy and outpatient rehab, with respect to some of the oversight areas of the government, and then a couple of detailed pages on resources in general. So SourceMed, we've been in the business an awfully long time, and we've really focused on the outpatient care sector. And our mission is to deliver, premier services and solutions from revenue cycle for rehab, surgery, specialty hospital facilities, and the whole post-acute care continuum, which is becoming critical as we move forward. And that's where all the patients are, and that's where they're all going. So that's a little bit about me. So you see who's on the other end of the line. I've been in business, I'll just say 20+ years, practicing, still say active in the associations, active with all of our clients, and look forward to continuing to help provide a little insight into some of the things that are going on. So let's talk about the current health market and some overview and trends at a high level. So there's lots of things going on, but some of the big ones we're seeing a lot more is technology. Lots of demands on technology, and a lot of these are related or linked. Because when you think about the MACRA Act passed last year and driving things like the MIPS program, alternative payment models, when we talk about population health and value-based payments systems that are being put in place, all of this is centered around sort of the triple aim of healthcare, and we'll talk a little bit about that as well. But the benefits are technology can really help all of us here, and where both in the physician world and in the outpatient or the post-acute care world and even physical therapy world, we've really been adopting technology at a much more rapid pace in the last 2 years, and I think more technology advances and use of technology will assist us, but also the patients are going to demand the use of technology going forward as well. So when we talk about technology, here are just some specific things to be thinking about, particularly in the post-acute care space, when patients are seen in multiple different delivery settings, and sometimes as a result of a condition they were treated for in the acute care center, or a surgical procedure that was performed, or just an ongoing a diagnosis that they struggle with, they're going to be seen by multiple different providers in those different care settings. Everybody wants their information to be able to move from one place to the other. How frustrating it is for you as a patient or even a provider to ask somebody to fill out multiple and duplicate forms, and all that information has already been provided to a previous provider for the same condition or treatment they're being seen for. So interoperability and be able to exchange that information is absolutely one of the most important segments, and we're seeing huge advances in that. We've been talking about it in healthcare IT for a long time, but more and more the government's helping drive this, and we're seeing more data sharing, secure data sharing, particularly from a HIPAA perspective, and making it easier not just for the provider, but particularly for the patient. And so the other interesting things is virtual healthcare. We've seen this in the physician space and other spaces. So when you talk about telemedicine or things like that, but we're literally also seeing in the physician practice space, which we'll probably start to see some of this in the outpatient rehab and physical therapy space, is virtual healthcare or virtual visits. How easy would it be to be able to leverage technology to see someone virtually, and they're being willing to pay cash for it, and not necessarily needing to lean on or leverage insurance. Ease of access to providers who can provide good information and care and can do it virtually leveraging technology is coming, and those are things we need to be prepared for. A big buzzword that's been around for almost 2 years now is patient engagement. And it means a lot of things. It doesn't just mean staying contacted with your patient, but it means the patient being able to contact you and being able to have access to the information they need to continue to drive their care. The patients, everything needs to be looked at from a patient-centric perspective, because the patients are no longer just patients. They're consumers of the healthcare services, and their demands of who they see, when they see, and access to care is going to drive an awful lot, and technology can help. That's on outcomes. You see people wearing wearable devices grow dramatically, and integration with those types of things, and to be able to keep people and follow up. And in our space, physical therapy, it's also critical to be able to do compliance. The more compliant our patients are, we've known this for years, the better outcome they're going to have and the more benefit they'll get when they do see us and have a visit. So we talk about the Medicare Access and CHIP Authorization Act, or MACRA, that was signed into law last April. A number of good elements came out of that. So the permanent repeal of the sustainable growth rate was one of them, because that was an ongoing battle that got kicked down the road for numerous years. So we didn't have to deal with some looming 20 or 22% cut in rates that got stalled at the end of the day, and having Medicare hold claims for 15 or 30 days, and interrupting your cash flows. So that's been repealed, and here's some of the payment updates. For this year, it's just a 0.5%, and then it flattens out in 2020 to 2025, and then beyond, you'll start to see things tied into the alternative payment models, and we'll talk more about that. But that was a big piece of legislation that impacted us. It also was it was the source of the creation for the MIPS program itself. So the merit-based incentive payment system we'll talk more about, provides for, is kind of the next step from your meaningful use program, your value-based modifiers program, and PQRS as well. So we'll talk a lot more detail about on a specific section on it, but it begins in 2019 from our perspective. It's beginning next year from the physician's perspective, and basically the bonuses will be on a sliding scale, but the penalties will begin at 4% in 2019, and they'll start going up 5% in 2020, 7% in 2021. So they start getting a whole lot stiffer from a penalty perspective than what we saw from the PQRS with the 2%, and I still know we even felt the sting of that as well. So the other components were, is alternative payment models, and so there's a number of those that are in flux, particularly part of the Innovation Center at CMS, and so participation in those, you can receive bonus payments, and so we'll talk more about that as well a little bit later on. But you're going to want to keep an eye on all of these payment models that are out there, some that are sort of in a research stage or trial stage, staying on top of those things. Value-based payments. So Health and Human Services, so here are the transition timelines that they kind of established. So 30% of payments, tied to alternative payment models by 2016. This is overall, not just for outpatient therapy or physical therapy. 50% by the end of 2018, and linking patient to outcomes. So it's a big move, right, from pay for reporting to a pay for performance, and we'll talk a little bit about that. So, you got to be able to, have quality, give quality care, prove you're having an impact to the patient itself, and the benefits, from a payment side will be there. So it's challenging, but it's a good thing. And I think where physical therapy and outpatient rehab in general, we can really start to show the value we bring to that patient overall, where maybe that's been a challenge before. So when you look at how things have trending, so no longer the fee-for-service. It's very quickly and fast a dying thing. It's still out there in numerous places, but if you see the trends and the adoption rates that have been occurring, this stuff is, fee-for-service is going away. You can't rely on that to run your business and to treat patients. Pay for reporting, it's been around for a little while, both on the functional limitations reporting and on the PQRS reporting. But while there's been some data that you can go out and see from a PQRS perspective, and not so much on the functional limitation reporting, there really hasn't been any really good benchmarking. So how do we compare as an industry against others? How does my practice compare to other practices? And how do the providers even in my practice compare to each other, so I can really start to drive and show the benefits and focus on areas I can improve and provide me more value. And then obviously the move is to, value-based payments, or really that pay for performance. You're starting to show that the quality of care we're delivering is impacting the patients. I can quantify it. I can show it based on these quality measures, and the good results of that will end up being payment adjustments in a positive way, maybe on a neutral way, and in a negative way if we're not doing the jobs we're supposed to be doing. So these alternative payment models, as I said, there's a number of them out there, and not to be confused with when we talk about alternative payment models. There's the new payment model that's all the buzz at APTA, and that's impacting us with the new eval codes, et cetera. That's certainly something that is coming, but from an alternative payment models, it's more of the ACOs that have been around there, the medical shared savings program, Medicare shared savings programs, right? The bundling of services initiatives that are out there in different spaces, and some in acute care and now coming into post-acute care. The comprehensive care joint replacement model that was discussed and initiates this year. So these are some of these payment models, and there's a lot of information on them, particularly on the innovation site in CMS, and I've got links to that later on in the presentation, and we'll talk more about these as well. Let's talk a little bit about another buzzword, population health. So population health is really, from the Institute of Medicine, it's really looking at the overall health of the population in general and looking at specific criteria, not just based on a diagnosis set or a condition, but also some of the other social attributes and parameters that may play into that. So it's different in the data that it looks at and the metrics it uses to provide value for the population health at large. And so it's a little different, and it's a good thing to look up and reference and have a sense of, because it's different from public health, and obviously the amount of data that's become available through technology. It's going to be very, very important to be able to drive and do more predictive healthcare and hopefully drive even better outcomes. And so a lot of the things that are driving some of these trends and everything else, it really is based sort of on the triple aim. So, the Institute for Healthcare Improvement kind of established the triple aim, and I left the link on here for you to go to their site. But really, the bottom line is all of this payment model, the shifting to pay per performance and quality and outcomes, it's all about how do we provide better health to the population in general, better care for the individuals and patients who require healthcare services, and how do we contain and lower the costs when those services are provided, get to the best provider, the most cost-efficient provider, and do it quickly and efficiently without over some burdens. And I think everybody will benefit from it. So that's a little bit of the overview of kind of some trends and stuff going on. Let's get into PCRS update. So I'd be amiss if I didn't go back and talk about 2014, and it sounds like, well, I'm not looking behind. Many of you know that how you reported in 2014 impacts how you're going to get paid in 2016, which is this year, right? And probably for the first time for a large percentage of providers, the impact on the lack or unsuccessful reporting in 2014 is hitting a lot of you. I heard comments and suggestions made by the APTA that about up to 70% of providers who were successfully reporting in the previous year actually failed to report successfully in 2014 and are suffering under a 2% penalty this year for non-compliance or not meeting the successful reporting requirements. And the bottom line is the culprit was a single measure in 2014 that still exists today. It's Measure 130. It's documentation of the current medication or medication management. And the reason was that measure in 2014 had two particular CPT codes that we tend to use an awful lot, 97110, which is therapeutic exercise, and 97140, which is manual therapy. On a daily, almost a daily basis, those codes are used with patients. And so if you didn't document this particular measure, every time you use those codes, or at least 50% or more of all the Medicare patients you saw, you probably failed that reporting requirement. So that single measure was definitively the culprit. There's other things that could have factored into it, but that was the unique difference in 2014, that those CPT codes were not required for 2015 reporting and also not required for this year. I left a link on here, a CMS link to the payment adjustment toolkit. It's a good link, really good resource. It talks about when you're experiencing a payment adjustment, what are things I can do. It provides really good information on what does that look like, and the responses I get back on the payments and the claims, et cetera. It's a good resource. So let's talk about 2016. Good thing is no changes from 2015, right? So that's a really, really good thing. So successful reporting requirements are the same as last year. Reporting, of the 9 measures, or 1 to 8 as applicable, 50% of all eligible patients needed to avoid the penalty for 2018, right? So available measures, there were no new measures, all the same measures. No coding changes to the report, so no special new CPT codes that are high frequency utilized that got stuck in like the change in 2014. And the reporting mechanisms are pretty much the same. So it's, registry, claims-based reporting, and still a high percentage of the providers are doing claims-based reporting. So compliance and challenges that we see in 2016. So obviously the eligible providers who bill under the physician fee schedule must report successfully to avoid that 2% reduction in 2018 fee schedule. PTs can report via claims or registry. Obviously rehab agencies, outpatient hospitals, SNFs, Part B, unable to participate. And basically if you bill on a UB, you don't have to participate and you're not subject to it. So to avoid the penalty, it's at least 9 measures or less, covering the professional. So from a claims-based perspective, that ends up meaning basically these are the 6 measures you need to report. These are the only ones available from a claims perspective. There are more than this. There are additional measures you can report if you're doing a registry. So these are the measures and the codes that go with them. There's some good links to them. But if you reported successfully last year, which probably most of you did in 2015, basically just continue to do what you're doing this year, and you should be able to successfully report this year as well. And so just, a quick view on your participation. So if you want to avoid the penalty via claims, here are the measures, still 6 measures to report, and registry, select 9 individual measures, or, it depends on the measure. Some measures have to have a positive response in order to report it. So as you report as many as are applicable based on the criteria. So again, just a summary of reporting options. So claims-based reporting, evaluate the patient, perform the measures, document the findings for for your related care, submit the claim, include all the codes, a 1-cent charge. They're billable but not payable. Don't add GP or KX modifiers to the PKRS codes. That'll cause a problem. And then make sure you're accessing the feedback reports through QualityNet. The link to the portal's here, and we'll provide that as a resource as well. But through the year, you can see how you're doing and how you're reporting at particular measures, so you make sure you don't end up in a position. And then if you want to look at registries, I don't know if they've updated the 2016 registries, but I believe all of the 2015 registries are also qualified registries for this year. And then if you want to look, there's some other links to Reporting Made Simple, takes you to the CMS sites. It's really, really good. I recommend using Photo. They have outstanding registry, and they provide a lot more outcomes, capabilities, and data, some good benchmarking information. That's just one that, being in the industry, I believe they're one of the best registries, particularly in our space. So here's things you want to avoid, right? So things that will cause you the PKRS to fail. So make sure the codes you include are eligible. Make sure that claims being submitted are for the sole purpose. You're not just submitting claims for the sole purpose of adding a PKRS code, right? You just can't resubmit in just for the purpose of adding the code. You know, avoid the modifiers. Huge problem with adding hard coding or adding the GP and the KX modifiers, you know, on these PKRS codes and these G codes. So, and you can't resubmit the claim to correct the code errors. So make sure you're mitigating that up front, and you'll dramatically impact that. And then obviously the other thing is failing to meet the 50% reporting criteria for all selected measures. It is important to note that each individual measure needs to meet the 50% reporting rate, right? So it's not just overall, it's each measure that should have been reported, you have to report that measure 50% of the time, and that's just a good thing to know. So a little bit of difference between sort of functional limitation reporting and PKRS. So, you know, there's a lot of differences and really only one similarity. So PKRS is about quality assurance program, right? Functional limitations is much more about outcomes. One's PKRS is voluntary and functional limitation reporting is required or mandatory, right? Only certain visits are eligible for PKRS reporting, and it's based on specific criteria, right? Age of the patient, maybe the procedures performed, diagnosis. Sometimes, depending on how they respond to a particular measure, or if a measure is applicable, there may be additional measures in PKRS you'll have to respond to. On the FLR side, right, they're mandatory for certain visits, eval, re-eval, the known discharge visit, any change in functional status, you need to report it in basically every minimum of every 10 visits. On the PKRS side, there's a financial penalty for non-participation, right? There's no bonus anymore, it's just in the penalty stage, has been for a little while. You know, and it basically for either not participating at all, which there are still a number of people who don't participate, or not successfully reporting. On the FLR side, the claim gets rejected, right? So there's just no payment, right? And you find out a lot more quickly than retrospectively like the PKRS. The only thing they really do have in common is both of their codes that you report start with the letter G. So finishing up a little bit on PKRS, you're getting near the end of PKRS stuff. So PKRS versus MIPS, right? So the Merit-Based Incentive Program. So many of you know or may not know that this is the last year to report PKRS. So 2016 is the last year to report PKRS because we will move into the Merit-Based Incentive Payment System. So big, you know, for the PKRS, report on the number of quality measures, 50% of eligible patients, pay for reporting, right? If you meet reporting requirements, no penalty. And then current measures are not always meaningful to the practice sometimes, depending on what you're doing. And in 2016, you basically, for claims-based, report on 6 measures for 50% or more of all visits, particularly for the 9701 and the eval and reval codes. Merit-based, there's 4 categories, and I'm going to go into more detail later about this. So for us, it's not going to start probably until 2019, so we don't have to worry about it right away. But there's going to be a quality measure component. There may be some PKRS measures that will be part of the new MIPS program. There's a resource use percentage. There's a clinical improvement activities and meaningful use. The meaningful use component, I'll talk about this a little later, is probably not going to be applicable for us. So that percentage will probably be spread over the remaining 3 categories when we start. But there's still some definition in some of these things as it's being rolled out that we'll keep an eye on and we'll continue to update you on. Providers will basically earn a score from 0 to 100, and they will be incentivized or penalized based on performance. So it's all about payment to perform, not just to report. There's an opportunity to develop measures meaningful to the practice. So versus doing a bunch of measures just for the sake of measures, whether they're meaningful or not, hopefully that is not going to be part of this program, that they will be meaningful to driving outcomes for our patients and our practice. And then CMS is going to be continue outlining further details of the MIPS program over the course of this year. So just a little, I'll touch on this briefly, but sort of the future of PKRS reporting. So as you can see, the calendar year 2017, you don't have to report, right? In 2018, you don't have to report PKRS. 2019 is when it switches to the MIPS program. So basically the PQRS program is being replaced by the merit-based incentive payment system. And so that's starting in 2017 for physicians, but we're not part of that right now. We will probably be part of that, and the Secretary will be adding us to that probably in 2019, as everybody assumes. So if we dig in a little bit more on the merit-based incentive program, and I do apologize for going very fast, but there's an awful lot to cover, and we are recording this again. So in detail, what does that mean? So I talked about the 45% quality measures, 15% resource, 50% clinical activities, and 25% meaningful use. So the PQRS measures, there are some pretty good indications that some of the measures or PQRS measures will move and become part of MIPS. Well, they'll just adopt those measures. But there's also going to be progress and outcome measures, so we'll be moving more toward true outcomes measures and not just the PQRS measures. And all new measures that are going to be published, all the measures going to be added, will have to be published in peer-reviewed journals or developed by the quality department program. So, so that's a really good thing. They're going to be specific, and I believe they'll add value and will really facilitate some good benchmarking. So the resource use, currently PTs don't have any measures in this category, so we're going to wait and see how this is going to evolve over the course of this year and next year. Clinical activities, this particular thing is not outlined yet, but the categories include expanded practice access, population management, care coordination, and beneficiary engagement. The beneficiary engagement piece, the Secretary will be required to specify what does he mean by engagement of the beneficiary or the patient, and specify what activities you're going to have to provide. And then meaningful use has been a big thing in the physician practice world, meaningful use 1 and meaningful use 2, but PTs right now, we don't play in this. We're not covered providers as part of meaningful use. And so the suggestion is the weight of this particular category will probably be redistributed to the other categories. So from a timeline perspective, so if you look at this year, report PQRS as you normally would, right? And the subject, so you report it in this year, and you're currently, from a payment perspective, you're being subject to a penalty because of reporting or not in 2014. In 2017, you don't have to report PQRS or MIPS, but you still could get the penalty in 2015. In 2017, you could be subject to the penalty if you didn't successfully report last year. In 2018, you don't have to report PQRS, but if you don't successfully report PQRS this year, you will be subject to that penalty from lack of reporting or failure to successfully report. And then 2019 is when the MIPS data will come into play. And so, as I said, the Health Secretary has the ability to add PTs to the program in 2017, but more than likely, if we get added to the program, we won't probably have to start reporting until 2019. And so right now, there is no scheduled payment adjustment, but we expect to start seeing reporting the data in 20, no payment adjustment, and then right now, reporting MIPS data in 2021, and then we would be subject to the penalty. So just more information. Lots of updates will come through our quarterly regulatory updates on this, but certainly want to make sure you're aware of it, and you can, there's lots of good links on this information, and it will become a very popular topic as we get through the year, and some of this is better defined. Okay, a quick update on Therapy Cap. So Therapy Cap is still around, and this year it's $1,960. Unfortunately, PT and speech are still combined, and I don't mean that negatively for the speech people, but OT has its own cap of $1,960, and we still have to share $1,960 with PT and speech, right? So it's still around until the end of 2017, and so that's, until a lot of these payment models that are coming up hopefully are going to end up replacing the value-based patient and the alternative payment models and the new payment model. So they kind of pushed it down the road. So that's a good thing. Really good Med Learns Matters article there to be able to link to. And again, that's in the resource thing as well. it's important to know that, the cap itself is based on allowed charges, right? So it's allowed charges, but it's after your MPPR has been applied, but before the 1.6, sequestration discount has been applied. So I put a little math in here. So if your allowed charges were $122.79 for the visit, discount payment after the MPPR is $111.40, right? So the $111.40 is the allowed charges, even though after sequestration it may be $109.61. Keep in mind that Medicare program only, pays 80% of the allowed amount. And there's a really good link here on the PowerPoint and on the deck and presentation to specific Medicare limits. There's also some good information about the deductible and how you manage and how you make sure you calculate that $19.60 accurately and effectively. So from an exceptions process, so the exceptions process is also still in effect through December 31st, 2017. So that basically means, if you go over the cap, you can apply that KX modifier to the codes, but it should be done, where it's warranted, where the services are required, the medical necessity, all the things we had to do to justify the cap being on there, we still need to continue to do, right? And so decision on whether or not to add it, is by the treating or supervising therapist, use of the modifier, basically you're attesting that services require the unique skills of a therapist or assistant under the supervision. There's no additional special documentation, just obviously that medical necessity is still being met, which you need to meet on a regular basis anyway. So clinicians may utilize the process for exception for any diagnosis or condition. So just things to keep in mind. The other thing on the cap is obviously manual Medicare review. So they changed this a little bit last year. So obviously this occurs when you exceed the $3,700 threshold. Again, there's a separate threshold for physical therapy and speech therapy combined, and there's a separate one for OT in the calendar year based on the allowed amount. Same allowed amount calculations, et cetera, that pertain to the cap as well. So the new process that began last year in July, so basically CMS is working with a partner to go in and look at therapy services that require review. And so if you have a certain criteria, you're going to be subject to review. So not necessarily everybody who exceeds the threshold will be reviewed, but based on the provider's patterns of apparent billing practices compared to their peers, high claims denial percentage, or less compliant with the program requirements for Medicare. A lot of providers who are newly enrolled may automatically become under scrutiny from a threshold by exceeding it. Providers who treat certain types of medical conditions, so if there are certain types of medical conditions based on the data supports those things being reviewed, then you're going to be subject to the manual Medicare review. And then providers who are part of a group that includes another therapy provider identified with the above factors. So if your practice has a couple of people, or if you have a couple of facilities who consistently seems to fall under Medicare review, more than likely that will continue as you go over these thresholds. So now some of the fun and new stuff. So innovative and alternative payment models. So again, as we talk about some of the things earlier, so moving from volume to value. So it's just not about the volume of service you provide, it's about the value of service you bring to the table and the value and quality of the impact you have on the patients you're treating. I really believe that physical therapy and outpatient rehab in general, including OTs and speech, I think we always believe we bring significant value. Our patients tell us that, and I think we know it. This is a great opportunity for us not to back away, but to press in, because I think this data and the good quality therapists, and I know that I've spent time around, and some who are most of our clients, this is an opportunity for us to really get paid for the value we provide the patients and the impact we have on quality for the patients themselves. So, so HSS has measurable goals and timelines, right? They tie payment to alternative payment models and performance. Their goals are basically, as I said, this is more globally, not just specific to PT or outpatient rehab, but 30% pay for performance by the end of 2016, moving to an alternative payment model, 50% by the end of 2018 to some sort of an alternative payment model, and then 85% to quality by the end of 2016 and 90% by 2018. So better models, which, you know, again, all of this is tied to the triple aim, right? So it's better health for the population, better quality of care for the individuals and patients, and lower cost and cost containment for the services provided. So when we look at the current quality programs under Medicare that are specific to PT, that are impacting us, and obviously there's multiple different healthcare settings and delivery models. So inpatient rehab, long-term care, inpatient rehab facilities, skilled nursing, home health, hospice, but I'm going to focus on outpatient. So from right now, we still have PQRS, right? And it's a pay-for-reporting penalty of 2% on an individual group basis based on either tax ID or the MPI, right? From a patient perspective, we have the functional limitation reporting, and that's based on, you know, the payment or incentive as a condition of payment. Basically, if you report it correctly, you get paid, your claim gets paid. If you don't, you don't. Your claim will be denied. But also the innovative models that come into play, right? The reporting level is at an organization or at the facility level. And these, you know, these include the bundled payment care initiatives, you know, the comprehensive care joint models, and so I'll talk more about those. So they're quality reporting requirements for each model, right? So when you think of an ACO, that's completely based on a value-based payment and shared savings sort of model, right? And if you look at pay for reporting, the BPCI is more along that pay for reporting right now. And then value-based payments also with certain quality thresholds is where we're going to start to see the total joint program come into play. So the major changes to the quality programs, you know, today, so what we're seeing, right, is from PQRS, now we're going to MIPS, right? MIPS will actually, as I said, begins in 2017. For the physicians, will start being under that next January under the merit-based incentive program payment system. So we will probably be included sometime next year, but we won't have to start reporting on it until 2019. And again, stay close to that, but we'll continue to update you on that. And that's a value-based payment system. And then from a patient perspective, we still have the functional limitation reporting, and that's still a condition of payment. It'll be interesting to see how that changes over the next year or two as well with all of the new payment models. So from the bundled payment initiatives that are ongoing, and there's lots of detail on these on CMS's site, and we got links to them for you that I want you to be aware of. On the innovation page, but you can go to them specifically. So the comprehensive care for joint replacement model, it's either called the CCGR or the CJR, pardon me, or the CJR, right? It's referenced in two different ways, but that's fine, however you want to refer to it. So it's a model that's kicking off in April this year, right? So there was some changes made at the end of the year in November on the final rule to kick this off, right? And so I'll talk more about specifics to it, but it's, you know, it's basically those, you know, total hip, total knee replacements, you know, looking at bundled payment and looking at the quality of those procedures that occur in a hospital, and as the patient moves into a post-acute care setting, to work together to how do you get better quality, and they're forcing coordination of care, right? So that whole interoperability piece that I talked about before. This is not just the hospital reporting on something, it's hospitals and post-acute care through that continuum of the patient until complete recovery, and right? And so it's really going to be interesting to see in total joints, while they had very good success with models in the acute care setting historically, with days of service or length of stay models a long time ago, this will persist as well. Other bundled payments for care improvement initiative. So this is a sort of 4 broad models, and I'll talk about them in more detail in a second. So there's 4 broad models depending on the care setting, and it's, you know, good to keep an eye on these. Right now, there's not as much involvement from our side on these. There's going to be a lot more involvement, obviously, from the orthopedic nature of the total joint perspective. So the CJR model, so CMS has implemented this model in 67 geographic areas, and I think on one of the next slides I have a list of all those areas. It's defined by metropolitan statistical areas, so MSAs, right? Counties that have a core urban population of at least 50,000 people. And so there's some non-MSA counties that were not eligible for this selection. So the whole goal is, better, more efficient care for the beneficiaries undergoing common inpatient surgeries for Medicare. It applies to the total hip and total knee replacements. In 2014, there's over 400,000 hip and knee replacements were performed. And hospitalization costs were, just for those procedures, were more than $7 billion. So everything is being driven by cost containment and driving better outcomes. So the average Medicare expenditure for surgery, hospitalization, and recovery ranges from $16,000 to $33,000, depending on the geographic area. And that's a pretty broad range. So they're trying to get a really good handle on this. So here's a list of the updated areas that were selected to participate in this model. So probably it's a pretty broad area. So you're probably near or close to one of these metropolitan areas that will be included and selected to participate in this. So you want to keep an eye on that. So kind of what does it mean from our perspective? So the model starts on April 1st, and you can put the link to the Federal Register that came out, right? Requires the hospital programs in those selected areas to participate. There's no change to the hospital or professional payments, right? The hospital financial incentives are based on complication rates, customer surveys, and cost of the hospitalization, plus 90 days post acute care or post DC. So they're very incentive to not just say once we discharge you, you're on your own. The 90 days post care is critical. This is a great opportunity for all those total joint patients to be coming and seeing therapists to get optimum outcomes. Just so you know, APTA has been engaged, and they're updating their webpage. There's some information out there, but I know there's a bunch more information that will be added over the next 30 days with this as we get close to April 1st. So I put the link to their page on that. They're really good at timely updates on all these changes since they're so close to DC there in Alexandria. So keep an update on those, and they usually do provide some good tools, clinical guidelines, and some best practices for being a part of this and certainly increasing your awareness. So from the bundled payments for care improvement initiatives, so there's 4 models that I talked about. And I'm just going to go over this really, really quickly. So the Model 1's inpatient stay only. Model 2 is inpatient stay plus 90 days post-acute care. Model 3 is just the 90 days post-acute care. And Model 4 is inpatient stay only again, but it's more, it's a different type of bundled payment model. So the payment for these is almost all fee-for-service, except there's a bundled payment model on Model 4. Again, put a link on this page. There's links on the resources page. It's good. I just said that Innovation Center, stay on top of that. But there's also some really good information on the ACO models that are out there, which, kind of faded a little bit, but are coming back. And we have a number of clients I know that participate in ACOs today and benefit from it. So you want to be engaged with that. So let's talk a little bit about the new payment model. And I know we're getting in the last little bit. So obviously, there's been a lot of buzz, certainly in physical therapy, particularly about the new payment model, and the APTA certainly took an active role in trying to drive some alternative payment system, et cetera, which they formerly called it the APS system, which is now APTA is calling it the Physical Therapy Classification and Payment System, or PTCPS, right? So it was renamed, refined by the task force. Their recommendations were submitted to the AMA for CPT code assessment and updates or inclusion. All of that is still under consideration. There are some new eval codes that will be coming out, I believe, next year in 2017 that will that will be part of the CPT codes. Whether they'll be required to be used or not, we haven't seen, so there's still some considerations. While APTA was very much at the forefront in driving a lot of this, I will tell you throughout our industry and space on the physical therapy and outpatient care, not everybody was in alignment or agreement with APTA. So I'll talk about a little bit more about that in a second, but just from a timeline perspective, I didn't include all of the history, but certainly the most relevant things that you want to pay attention to, which is what happened last year with the APTA and AOTA, Occupational Therapy Association, for spending the evaluation re-eval codes that they worked on in the subgroup. And then in July, the Medicare Physician Fee Schedule proposed rule will be released, which it typically always does for comment period, and it will include the proposed values for physical therapy and occupational therapy eval and re-eval codes. And there'll be a 60-day comment period on that proposed rule. And APTA is going to be doing a lot of comprehensive education campaign around these codes, but you know, APTA is going to have strong opinions on this because they supported and drove these code changes, and not everybody agrees with that at this time, and I'll talk about that in just a few seconds. And then October and November is when the final rule will be released, as you know, for the physician fee schedule, which it always is, probably closer to November, and so that will have final values for these new PT, OT, eval, and re-eval codes. And then January 1st, 2017 is when we expect implementation of these new physical therapy and occupational therapy codes. So throughout the year, just keep in mind that I will be updating you on these in my regulatory updates, and also anything in between those regulatory updates we'll be updating you on. I also included a link right here to the homepage on the APTA site specific to that payment model. So now I want to talk about some other groups that are very active, made up of what I consider to be some of the thought leaders in our space on the private practice side of the business, and not just on the private practice side, but from the corporate side, private practice side, small practice, medium practice, and large practices. That not everybody agrees with the decisions that were made by the APTA, and since there's an awful lot more therapists, as you can imagine, practicing today, and you may be one of them, that are not a member of APTA, since they only represent about 70-odd thousand physical therapists. So I really recommend that if you haven't, that you go out to the Alliance for Physical Therapy Quality and Innovation, go to their site, see what they're doing. As you can see, they've got 15,000 therapists strong as part of their membership. They cover all 50 states. Over 4,000 clinics that provide services are represented, and they're serving 3 million patients, you know, on an annual basis. So, you know, you may want to go look at the pilot study that was done on the code set. You know, it wasn't very successful. APTA has been a little bit of withholding with, you know, some of the results from some of the, you know, the studies that he did on some of the codes. So there is a real grassroots, and it's more than grassroots because I said it's industry and thought leaders that are really coming together and saying, you know, I don't know if we just want to accept what APTA is working with AMA as the new codes we're going to build from and impact the payment model and the livelihood and the patient's retreat, how we get paid, and our ability to run our business and practice. So I really recommend they have some of their own suggestions on some payment model tweaks or changes to improve it, and I really strongly recommend, if you don't, I'm not saying you need to join or become a member, but you should be following this as much as you follow APTA or anything else. And sort of in alignment with that, another organization, and there's overlap between some of the leaders, et cetera, in the organization. So obviously the Physical Therapy Business Alliance is another group. Sort of the managing director of that's Chuck Felder, who's certainly a thought leader in our space, and been around the business for a long time, and a number of others. So, you know, here's some comments made by them. We know CMS is phasing out the PKRS system, and the, you know, the MIPS is coming in. We also know, you know, they also say we know APTA has been working with the AMA work group to alter the code levels, you know, but they believe that both themselves and the Alliance, know that the payment reform affects every single therapist and not just members of APTA. And so working together to be completely transparent on what this is going to be, to make sure we get a payment model that's not only acceptable, but allows us to continue to provide the service and plethora of services we can cost effectively, but also so that we can still run our business. And so that's a great, another great alliance and group to manage, track, and they do some really good town hall meetings and webinars that I strongly recommend you look at, review, and consider. So some other regulatory updates, just lots of interesting things going on. So the wonderful Office of Inspector General has a great work plan, and so that came out for this year, and it is there's a number of core things that of interest to us, and things that they will be targeting specific to physical therapy. So there is a focus in the work plan on outpatient physical therapy service provided by independent therapists with really high utilization rates. So they're going to be looking at compliance with the Medicare programs. States with prior findings, which there was a number of them, some in Florida and some others, where claims were completely unreasonable or not properly documented, or the therapy services were not medically necessary for outpatient physical therapy services to be performed. So I provided a link and copy of the work plan. It's a pretty big document, but at the same time, you can easily search through it and find the area specific to outpatient physical therapy services to get a sense of what they're looking at, what they're going to be doing, because these are things that will lend itself into oversight, audit, et cetera, that you want to be paying attention to. The other really good resource to keep you educated and informed. So there was some comparative billing reports done by a group called eGlobalTech, and they were done in November last year in 2015. And so really good comparative billing reports across the space. Also looking at the analysis for PT included codes like the eval code. Therax, obviously manual therapy, therapeutic activities, some of the eSTEM codes, et cetera, right? All the information was also shared with the MACs. So the link on here that I put, and it's also in the resource, takes you straight to the webinar. And so you can actually watch the webinar. There's an excellent PDF handout of their results and report that you can download to get a very good sense of. And so you can really see, how you guys are billing individually and utilization of some of these codes. And so it's very educational information to help proactively prevent, manage your practice to make sure you're not getting into a situation of inappropriate or excessive utilization of certain billing codes, et cetera. So I'd really recommend that if you don't go through the webinar, at least download some of the slides and content, and it's good for, really good for digestion. So we're kind of coming near the end here, and I appreciate your patience. A lot of information covered in a relatively short period of time, and we're going to stay very topical in some of the presentations going forward. So continue to update you on a number of these things. But while I had a number of different links throughout the presentation on that particular topic, whether it be MIPS or therapy cap or PQRS, or some of the payment model or some of the bundling payment initiatives as well, I pretty much have summarized a lot of the links here for you as well. So from PQRS, the CMS homepage link right there, that Medicare payment adjustment tool link, which you may want to access specifically if you were someone who was subject to that 2014 reporting unsuccessfully, and understanding how that payment adjustment is going to impact you going forward on your Medicare payments this year. That's a very good link to that tool set. Just the APTA link for PQRS, they continue that updated. And then the QualityNet link. I don't know, I think everybody who reports PQRS, you should already have an access and log into the QualityNet system. And I know sometimes they've switched systems over the last year or so in the former system you accessed. It's a new landing page and new area, but they're supposed to provide you quality quarterly reports on how successful you're reporting and be able to track that. It helps mitigate any surprises at the end of a year or a year and a half later getting a letter about unsuccessful reporting and about to receive a penalty, since so much of the PQRS reporting is retrospective. The more you can stay on top of it by managing and being in QualityNet and having someone who's dedicated to do that on a quarterly basis and present the results to your organization, I think is very, very important. The MIPS, obviously the Quality Measurement Development Plan. There's a link to the draft here on it, both for MIPS and the alternative payment models. And we'll be using social media to update those. I'll be tweeting out any significant changes in the MIPS program that everybody needs to be aware of, as well as including this on the quarterly regulatory webinars that we'll be hosting and providing for you guys. And we're going to be continuing building out a number of toolkits and pieces that we'll have for our clients and make available, whether it's quick tips, informational things that you can download for all of these things to help manage and run your practice as well. Same thing for the therapy cap. Some really good, the MLM matters for the 2016 cap download link. You also got the cap limits link, and there's some really good information about managing the deductible, or how to manage the 1960, what is allowable and how do I track that more effectively. Obviously it's a financial number, but what's included, what's not, so you have a better sense of when you're going to go over the cap. And then the new payment models, the APTA site for their program that they've submitted and started on, but also the links to the Alliance, which I think is a great organization, as well as the PT Business Alliance. I think those groups are really, they're gaining a lot of awareness, and they're really going to have a voice, but they need your support as well to be able to be heard, because once this new payment model starts, coming into fruition, it's, as we know, with therapy cap and with sustainable growth rate, it takes an awfully long time to change things. And so the more we're out front and voicing loud and clear how this is going to impact not just organizations or companies, but all your staff and therapists, it's going to impact, this is something that can impact your livelihood and my livelihood as a physical therapist to provide the care I want to. So I really, not trying to get on a soapbox, but I'm on a soapbox. We can't stay silent on this. Links to the OIG work plan for 2016 for the fiscal year, that link's there. And also, I put a link to the Section 220 and 223 with the CMS regulations and guidance manuals for things that are going on this year. I think that's a really good thing to look at, as well as the eGlobal Tech Comparative Billing Reports webinar link that they did in November. That link was where you can also download the PDFs and watch the webinar, et cetera, and then links to the payment models. And as you go to some of those links, you'll notice that if you just go back once you go to some of those links, or take you right to the models. But I would say spend some time on the innovation page, right? So that innovation section of CMS website is where you'll see lots more information about ACOs, which I didn't cover in detail today. But those are, you want to be able to stay informed with all the things coming down the pipe, not just from a technology, but also being an election year, but with all the payment models and alternative payment models, and some of these new initiatives and innovations things, driving cost, again, everything targeted around the triple aim, right? Better health care for the population, or better quality of care for the individuals and the patients who are seeking care, and cost, lower cost, cost controls, cost containment. Well, I think I've eaten up a little over our time. I'm sorry if I went too fast. A lot of information to cover, and I really appreciate you carving out part of your day for this. As I said, all of the slides and the recording we'll make available to all of the registrants, and we appreciate your time. Megan, did you have any closing thoughts?
Just wanted to reiterate that this will be available. We will email it to you via the email address you used to register for today's presentation, and we'll also make it available on our customer community in the training or resources section, but I'll include that information in the email as well. Again, thank you so much for your time. David, thank you for all of this great information. We hope that you all found it valuable and join us next quarter.